Hello, my name is Joshua Clapp. I'm a fifth-year general surgery resident at the University of Louisville, and I'll be presenting our study from our institution in which we compared outcomes of per-oral pyloromyotomy and robotic pyloroplasty for the treatment of gastroparesis. I have no disclosures. A brief background to gastroparesis. It affects approximately 5 million U.S. adults. This is mainly due to type 2 diabetes. However, there are various other causes as well, including type 1 diabetes, post-surgical, drug-induced, and idiopathic. There's an increasing incidence of gastroparesis in the U.S., and this is likely due to increasing incidence of diabetes as well as increased awareness of the disease process. Initial treatment is generally medical and is focused on dietary changes as well, including more frequent, smaller meals, along with medications such as pro-motility agents, including metoclopramide and erythromycin. When symptoms remain despite adequate medical therapy, or there are contraindications to continued medical therapy, surgery is indicated. There are multiple types of surgical interventions, including Roux-en-Y gastric bypass. However, this is a quite invasive operation with significant comorbidities. Gastric electric stimulation with a gastric pacemaker is another minimally invasive option that has pretty good results. However, it does require permanent prosthesis as well as future battery changes. There are also operations on the pylorus that encourage emptying of the stomach, including laparoscopic and robotic pyloroplasty. Per-oral pyloromyotomy is a completely endoscopic procedure that is another minimally invasive option that is shown to be effective in the treatment of gastroparesis and is similar to laparoscopic pyloroplasty. In our study, the purpose was to compare the effectiveness of endoscopic per-oral pyloromyotomy to the established pyloroplasty. Diagnosis of gastroparesis was determined using a gastric emptying study. Our main outcome was symptom relief as determined by gastric cardinal symptom index, both preoperatively and postoperatively. GCSI is the most commonly utilized scoring method to evaluate gastroparesis. It is done by scoring 3 different categories on a scale of 0 to 5, with 5 being the most severe. These categories include nausea and vomiting, postprandial fullness, and bloating. The gastric emptying study at our institution is done using a technetium-labeled egg meal that is then studied over several hours to determine the percentage emptied over a specific time interval. This is then compared to a control group. Our data was collected prospectively from 2018 through 2021. Patients were offered either per-oral endoscopic myotomy or pyloroplasty, and procedures were performed according to patient wishes. Patients with non-governmental insurance policies regarded POP as a non-reimbursable experimental procedure, and these patients who desired POP and that had that specific insurance were scheduled for pyloroplasty. We also included all patients at our institution undergoing both these operations. Just to describe the operations for a bit, robotic pyloroplasty is a fairly standard operation. At our institution, we utilize 4 robotic ports with an additional 12mm assistant port. After our ports are placed, upper endoscopy is used to confirm the pylorus location, and a longitudinal incision is made from the stomach and onto the duodenum for a total of 4 centimeters. The defect is then closed in a transverse running fashion in 2 layers with absorbable suture. The endoscope is then reinserted and used to examine the closure from within the lumen and to perform an air leak test. Per-oral pyloromyotomy is a completely endoscopic procedure that has been described at this conference previously. At our institution, this is done under general anesthesia. An upper endoscopy is performed and that pylorus is identified. A submucosal bleb is created using a colloid solution approximately 3 centimeters proximal from the pylorus. A mucosotomy is then created using cautery. A submucosal tunnel is dissected out using the endoscope. The circular pyloric muscle fibers are identified and divided using electrocautery. The endoscope is then removed from the tunnel and endoclips are used to close the mucosotomy. Postoperatively, the upper GI contrast is performed to ensure there are no leaks that same day and the patient is discharged that evening. In our study, we examined the listed preoperative characteristics for both operations, including gender, race, age, BMI, ASA class, and GCSI. Operatively, we looked at the length of the operation and intraoperative or postoperative complications. Postoperatively, we looked at the GCSI score, change in GCSI, and whether they had significant continuation of their symptoms. Overall, we had 111 patients who underwent either per-oral pyloromyotomy or robotic pyloroplasty. Of the pyloromyotomy group, 16 were lost to follow-up and 11 were lost to follow-up in the robotic group. On this next slide, these are the preoperative and perioperative characteristics by surgery type with POP on the left-hand side. As you can see here, the two surgery groups were very similar in terms of most demographic and clinical characteristics. Patients who underwent robotic pyloroplasty had higher rates of reflux symptoms and proton pump inhibitor use, while patients who underwent POP had higher rates of governmental insurance. We had one major complication in the POP group, which was a leak that was identified 24 hours postoperatively and was repaired in open fashion. And we had a death in the POP group as well that was recorded. This was due to an overdose of promethazine that happened on post-op day 20. And then readmission rates were also slightly higher for POP versus pyloroplasty. Although not statistically significant, there was some evidence that the pyloroplasty group had more severe disease burden as measured by GCSI. Also, the operative time was significantly shorter for the POP group, as would be expected. Follow-up data was available for 74 of the initial 111 patients. Comparing those lost to follow-up to those with postoperative data, there was no significant difference other than race. Therefore, the data seems to be representative of the original cohort. Both groups showed a statistically significant decrease in post-op GCI. However, the magnitude of change was significantly more in the robotic pyloroplasty group. We then did a multivariate linear regression, controlling for the confounders that were different in our preoperative characteristics. This include insurance status, presence of reflux symptoms, and PPI use. This table shows that pyloroplasty is associated with a significant decreased score, more than the oral pyloromyotomy when controlling for these characteristics. To summarize the results, there was no significant difference in postoperative complications, but there was a significant difference in postoperative GCI outcomes. Pyloroplasty had a superior response with a more robust decrease in GCSI. We had two hypotheses as to why this occurred. One is that the increased intraluminal diameter during the pyloroplasty allows for more significant emptying of gastric contents into the small intestines. The other hypothesis is that during the per-oral pyloromyotomy, a small amount residual pyloric muscle may remain, leading to a small amount of retained pyloric function. Some limitations to this study. This was a single institution and a single surgeon's data. There were a few postoperative gastric emptying studies as well. And this can make it difficult to directly compare to previous studies which have included this. There was also a fairly short-term follow-up for these patients, only about 4 months. And it'd be interesting to see how these outcomes change in the months and years to come. In conclusion, robotic pyloroplasty and oral pyloromyotomy show significant improvement of symptoms in patients with gastroparesis. Pyloroplasty is a superior response to oral pyloromyotomy with similar complications and a longer operative time.